First of all, where were we standing before hypocretin receptor antagonists were developed? These drugs were developed from 2006, 2007 on. So they have been developed over the last, let's say, 15 years. But before that, what we had were drugs that worked basically on the GABA, on GABA. These were the classic benzodiazepines and also the so-called benzodiazepine receptor agonists. Benzodiazepine receptor agonists are also being called SET drugs, and these are zolpidem, these are zopiclone, and also a drug that is less well known, which is saleplon. Okay, all these drugs, what they do is they facilitate the effect of GABA upon the calcium channels in the brain. Ultimately, they have an inhibiting role on the neuronal cell. They will inhibit neurons. The main clinical problem of using GABAergic drugs was, first of all, the potential for tolerance, for pharmacological tolerance. This is why people that are taking benzodiazepines for longer periods of time frequently developed a pharmacological tolerance. So that means they need more of the drug to produce the same symptom, and also strong cognitive side effects. There is a loss of particularly memory, also attention, but particularly over the long term, there is a loss of memory over the long term. No? And these drugs are approved for short periods of time. The most that the benzodiazepines are approved for in Europe is 1 month. In the United States, zolpidem is approved. Well, it's not exactly zolpidem. It's an extended release form of zolpidem. It's approved for up to, if I'm right, 6 months or a year. I'm not sure of that. But again, these drugs are normally being used for short periods of time. So, that leads us to hypocretin. Hypocretin is a substance that was described first in the year 2000, and it was found that it's produced in a small set of neurons within the lateral hypothalamus. These neurons project widely to most of the cortex and exert, these hypocretinergic neurons project widely and exert stimulating effects on the cortical cells. That means that hypocretin is the main stimulant in the brain. It's necessary to stay awake. Without hypocretin, you will have difficulties staying awake for longer periods of time. All that has been tested many times in animal models, in vitro models, etc., etc. What is the clinical use of hypocretin? Well, we know that in a disorder called narcolepsy, which is characterized by an excessive daytime sleepiness, this, particularly narcolepsy type 1, these patients with that condition do not produce hypocretin. Why? Because the cells, the neurons in the lateral hypothalamus that produce hypocretin have been killed. Why these neurons have been killed, whether an autoimmune attack or something similar, it's a matter of debate. It's very likely that it's something autoimmune, but that's a different story. So in narcolepsy, whenever you have zero hypocretins in the CSF, or a minimal amount, at least a minimal amount of hypocretins, you will experience difficulties staying awake for longer periods of time. What would happen if we develop an antagonist of these hypocretin receptors? And that was the origin of this hypocretin receptor antagonist. The first of them was Daridorexant, which is it's a drug that is licensed in the United States, in Japan, but not in Europe. And lately, two additional hypocretin receptor antagonists have been developed. One of them is the one I'm going to talk about. Both of them are in the process of approval, but I'm going to talk about the phase 3 program on Daridorexant. So what Daridorexant does is it blocks, it antagonizes the two types of hypocretin receptors, which are the type 1 and the type 2. Two things are needed in order to understand the action of Daridorexant. One of them is that how quickly is it absorbed? What is the time to Tmax? Well, the time to Tmax of Daridorexant is 1 to 2 hours. So within 1 to 2 hours, the highest plasma concentrations are being reached. That's quite, compared to other hypnotics, that's quite fast. So that would mean potentially that Daridorexant could become a valuable drug for sleep onset insomnia. Yeah. The other one is the half-life. Please keep in mind the half-life of Zolpidem, for example, a widely used drug. It's as I said before, a benzodiazepine receptor agonist. The half-life of Zolpidem is 4 hours. Okay, for Daridorexant, the half-life is approximately 8 hours, a little bit less than 8 hours, 7 to 8. So that means that theoretically, patients with problems with sleep maintenance, insomnia, would benefit from the drug. So it's quick in getting in, and it stays there long enough to cover most of the night. The number of 8 hours is particularly interesting. I mean, the half-life of 8 hours is particularly interesting because these hypnotics, drugs that are being used for insomnia, if the half-life is too long, what you will get frequently is next day residual effects. So having something that is very much tailored for the 8 hours duration at night is particularly interesting. Okay, and this is where the information that we had. There had been a phase 2 clinical development program for Daridorexant. In this phase 2 program, two things were found out. First of all, we knew that the effective dose of the Daridorexant would be either 25 or 50 milligrams per day. You would reach the highest effects either in 25 or 50 milligrams per day. And also the side effects profile had been investigated. Nothing particular to worry on side effects with Daridorexant. And also we had investigated the effects of Daridorexant in the elderly population, in the population that was over 55 years old, in the older segment. Okay, and with that information, we came into the phase 3 trial. What I'm going to present is it's a mixture of two different trials. In one of these trials, the difference between, these trials consisted basically had something in common, and both of them lasted 3 months. The two trials, with an extension period of up to almost 1 year. The only difference between the two trials was the doses of Daridorexant that were being used. In one of the trials, in one of the trials, what we used was an arm. There were 3 arms. One of them was placebo, and the 2 other arms included 25 milligrams and 50 milligrams. In the other trial, there was a placebo arm, and there was 2 arms with 10 milligrams and 25 milligrams. Summarizing the result of the 3-month treatment period, in terms of efficacy, what we found is that 50 milligrams of Daridorexant were effective for treating sleep onset insomnia, and also they were effective for reducing the latency to sleep. Latency to persistent sleep, which is a key endpoint in our studies. So the latency for persistent sleep is diminished if you compare with baseline by 30 minutes. If you compare with placebo, by approximately 20 minutes. So it's quite significant. All that on 50 milligrams of Daridorexant. The other key endpoint that was improved was wake after sleep onset, the so-called WASO, wake after sleep onset. So that, in a sleep study, in a polysomnographic study, wake after sleep onset is all the period staying awake once the patient has reached the first sleep. So if you take long to fall asleep, that's counted for as latency to persistent sleep. However, WASO is once you reach the first stable sleep, is all the subsequent period of wakefulness during the entire night. So it's a kind of marker for sleep maintenance insomnia. And there we saw also that the 50 milligram treatment was able to reduce the WASO by 30 minutes on the average. As a result of that, total sleep time was increased. That for the 50 milligrams dose. For the 25 milligrams, it was somewhat similar. The only difference for 25 milligrams is that there is no significant effect on latency to persistent sleep. In other words, 25 milligrams are not sufficient to treat sleep onset insomnia. For sleep onset insomnia, if everything you want to treat is sleep onset insomnia, you might need to go to 50 milligrams. However, 25 milligrams might be sufficient to treat WASO, wake after sleep onset. So there is another question. The other question is, what is the effect, the next day effect of these drugs? Are we just treating sleep, or are we treating a 24-hour problem? And that's one of the main concepts around insomnia. It's a 24-hour condition. What we're ultimately treating, of course, we want to increase the amount of time patients sleep at night. But basically, what we want is the patient to feel better in the morning. This has been always a problem in studies with hypnotics, because there are no good endpoints for that. Sometimes people measure that by means of performance tests. We've done it in phase 2. The DSST, it's a digital symbol substitution test. It's a kind of performance test to see how awake the patients are in the morning. We can also use rating scales for mood in the morning, etc. What we did according to FDA rules was to develop a new questionnaire, which is the so-called ISTIC. These are the initials for, The ISTIC is a questionnaire that measures the next time residual effects, the well-being of the patient on the next day, not on the long term, on the next day. And what we found was that after 3 months, not after the first month of treatment, but after the third month of treatment, 50 milligrams, both 50 milligrams and 25 milligrams were able to improve it. Particularly the 50 milligram dose of Daridorexant were able to improve the ISTIC, the next time of well-being of the patient. And finally, a last word on side effects. Approximately 1/3 of the patients reported at least one side effect. The main side effects were either headache or nasopharyngitis. Both of these side effects occurred following treatment with 50 milligrams. And just one of them, the nasopharyngitis, occurred following treatment with 25 milligrams. The phase 3 program also included an extension period, a follow-up, almost 1 year period of follow-up. That can be summarized is that whatever, they were followed up on the same dose for up to a year, almost a year. What we can say about the follow-up program that I will just also show briefly is that nothing that had not been found on the short term came up new. That means no new side effects, which is important, and also that the efficacy of the drug was maintained over the 1 year. And that can be shown very, very, very easily on the slides. So there was not a diminution of efficacy over the long term.